Bismillahirrahmanirrahim. Hello friends. Today we will discuss about the metabolic response to injury. Objective of today's lecture is homeostasis component of response, mediators of response, phases of response and key elements, factors which exaggerate and avoidables. First of all, we will discuss about the homeostasis. What is homeostasis? Maintenance of a nearly constant condition in the internal environment. Essentially, all organ and tissue of the body perform functions that help maintain these constant conditions. Homeostasis is the foundation of normal physiology. Stress-free pre-operative care helps to restore homeostasis following elective surgery. Resuscitation, surgical interventions, and critical care can return to severely injured patient to a situation in which homeostasis become possible once again. Nature of injury response. Metabolic response to the injury is graded and evolve with times. As there is a graphical image showing that there is a between graph plotted between resting metabolic rate and stage. In starvations, the metabolic rate decrease. In minor and major trauma, there is increase in metabolic response. There is a key factors which help in injury response are immunological, hormonal, and cellular response. Response components, we have physiological consequences, metabolic manifestation, clinical manifestation, laboratory changes. In physiological changes, we have increased cardiac output, increased ventilation, increased membrane transport, weight loss, and wound healing. Metabolic components are hypermetabolisms, accelerated gluconeogenesis, enhanced protein breakdown, increased fat oxidations occur. And clinical response components are fever, tachycardia, tachypnea, presence of wound or inflammation, anorexia. Laboratory, we have leukocytosis, increase in the WBCs, leukopenia, decrease in WBCs, hyperglycemia, increase level of the glucose in the blood, elevated CRP, altered acute phase reaction. CRP means C-reactive protein. Hepatic or renal dysfunctions may occur. Mediators of the injury response, we have neuroendocrine, hormonal, or we have immune system cytokines. In neuroendocrine response to the injury and critical illness, we have biphasic, which means we have acute phase and a chronic phase. In acute phase, an actively secreting pituitary and elevated counter-regulatory hormones like cortisols, glucagon, adrenaline changes are thought to be beneficial for short-term survival. In a chronic phase, hypothalamic suppressions and low serum levels of the respective target organ hormones changes contribute chronic wastings. And there is a diagram showing the endocrine pathway. If there is an injury, so the afferent nociceptor pathway of the pens send signal to the spinal cord and spinal cord to the upper areas like brain, cerebellum, medulla, and there goes to hypothalamus. In hypothalamus, there is a release of CRP, corticotropin releasing factors, and released by the pituitary glands, which rise the hormone ACTH and growth hormone in the plasma. ACTH then act on the adrenal to release cortisols. Hypothalamic activation of sympathetic nervous system stimulates the release of adrenaline and glucagon. Corticotropin releasing factors release from the hypothalamus increase adrenotropic hormones released from the interior pituitary. ACTH then acts as adrenal gland to increase the secretion of cortisols. Hypothalamic activation of the sympathetic nervous system causes release of adrenaline and also stimulate the release of the glucagon. Intravenous infusion of a cocktail of these counter-regulatory hormones like glucagon, glucocorticoid, and catecholamines reproduce many aspects of metabolic response to injury. Innate immune systems, principally macrophages, interact in a complex manner with an adaptive immune systems like T cell and B cells in co-generating the metabolic response to injury. Purpose Purpose of the neuroendocrine response is to provide essential substrate for the survival, postpone anabolisms, optimize host defense. We have immunological response, which are divided into pro-inflammatory phase and counter-regulatory phase. In pro-inflammatory phase, we have interleukin 1, interleukin 6, TNF alpha, hypothalamus, which hypothalamus pyrexia by acting on a hypothalamus, proteolysis by acting on a skeletal muscles, hepatic acute phase proteins which lead to the SRIs if not treated, and they goes on to MODS. Counter regulatory phases: interleukin 1 receptor antagonist and TNF soluble receptors prevent excessive pro-inflammatory activity, restore homeostasis. Compensatory and anti-inflammatory response syndromes occur. Phases of physiological response by the David Cuthbertson in 1930. If the injury occurs, the first phase, which is followed is F phase, which occurred in the horse after the uh, after the after the finishing of the F phase. We have flow phase, which goes up to the days. After the flow phase, we have recovery phase. F phase means shock, and we have hypothalemia, hypothermia, and a flow phase we have catabolism phase, breaking down energy stores. Like there in flow phase, the body is in the phase of wound healing. So wound healing needs energy. So the body is in the phase of catabolisms. There is a breakdowns of the energy resources like skeletal muscles, like fats, and like glycogens. And the recovery phase, which anabolism, buildings up energy store. Recovery, like those muscles or energy stores are waste in the flow phase. During the recovery phase, building of these energy occur. Ebb and flow phase. In F phase, duration of F phase is 24 to 48 hours. Right. Role of the F phase are conserve blood volume and energy reserve for the repair and regeneration. Physiological changes occur: decreased BMR, decreased temperature, decreased carbon monoxide, hypervolemia, lactic acidosis may occur. Hormones which are involved in F phase are catecholamines, cortisols, aldosterones. Flow phase. In flow phase, we have two divided into two phases. One we have catabolic and we have anabolic. In catabolic phase, it goes into 3 to 10 days. Mobilization of energy stores, recovery and repair, mobilization of energy stores for the recovery and repair. Physiological changes: increased BMR, increased temperature, increased oxygen consumptions, increased carbon monoxide. Hormones which are involved in cytokines, increase in insulin level, glucagon level, cortisols, catecholamines, but insulin resistance also increase due to the catabolisms. Anabolic, which duration is 10 to 60 days after the injury, role is replacement of lost tissue. As we discussed that anabolic phase, anabolisms occurs from the small molecule. There is a buildup of large molecules or energy sources for the body. Physiological changes, positive nitrogen balance occurs, and hormones which involve in the anabolic phase of flow phase are growth hormones IGF. Key catabolic elements of flow phase: hypermetabolism occur, alter in a skeletal muscle protein, alter in a liver protein, insulin resistance. Hypermetabolism: majority of the trauma patient energy expenditure approximately 15 to 25% occurs, which predicted healthy resting values. Factor which increase these metabolisms is by the central thermodysregulations, increased sympathetic activity, increased protein turnovers, wound circulations, abnormalities may occur. Number 2, skeletal muscles metabolism start. Number 1, muscle wastings, results of the increased muscles protein degradations plus decreased muscle protein synthesis. Cardiac muscle is spared. Number 2 is mediated at a molecular level mainly by activation of ubiquitin protease pathway, which lead to increased fatigue, reduced functional ability, and decreased quality of life, and increase the risk of morbidity and mortality. Number 3, we have hepatic acute phase response, which is started by cytokine interleukin 1, interleukin 6, which lead to increased synthesis of positive acute phase protein, fibrinogen, and CRP. Negative acute reactants are albumin decrease, not compensated. Insulin resistance also occurs as a hyperglycemia is seen. Hyperglycemia increase glucose production plus decrease glucose uptake peripheral tissue. Transient induction of insulin resistance seen due to cytokine and decreased responsiveness of the insulins and regulated glucose transporter proteins. The degree of insulin resistance is infinity to magnitude of the injurious process. Changes in body compositions following surgery and critical ill patients, catabolism, decrease in fat mass and skeletal muscle mass, body weights, and paradoxically increase because of expansion of extracellular fluid spaces. Factors which increase response to the injury: hypothermia, pain, starvation, immobilization, sepsis, hypotension. Avoidable factors that compound the response to injury is continuing hemorrhage, hypothermia, tissue edema, tissue under perfusions, starvation, immobility. Avoidable factors: volume loss, careful limitation of intraoperative administration of colloid and crystal colloid so that there is no net weight gain. Hypothermia, maintaining normal thermia by an upper body force air heating cover, decrease wound infection, cardiac complications, and bleeding and transfusion requirement. Administration of activated protein C to critically ill patient has been shown to decrease organ failure and death. It is thought to act in parts via preservation of microcirculation in vital organs. Maintaining the normoglycemia with insulin infusions during critical illness has been proposed to protect the endothelium and thereby contribute to the prevention of the organ failure and death. Avoidable factors. Starvation. During starvation, the body is faced with an obligate need to generate glucose to sustain cerebral energy metabolisms, which is 100 grams of the glucose per day. Provisions of at least 2 liters of IV 5% dextrose for fasting patients provide glucose as above. Tissue edema is mediated by the variety of mediators involved in the systematic inflammation. Careful administration of anti-mediators and reduced fluid overload during resuscitations reduce this condition. Immobility has been recognized as a patient stimulus for inducing muscles, a potent stimulus for inducing muscles wasting. Early mobilizations is an essential measures to avoid muscles wasting. Approximate to prevent unnecessary aspects of a stress response, we have minimal access technique, minimal period of starvations, epidural analgesia, early mobilizations. By these methods, we prevent unnecessary aspect of stress response. There is some BCQs which if you can solve these BCQs, so comment below the answers. I will reply you with the correct answers. The stress response, which one of the following statement is false? A. Metabolisms and nitrogen excretion are related to the degree of stress. B. In such situation there are physiological metabolism and immunological changes. Number C. These changes cannot be modified. Number D. The mediators to the integrated response are initiated by the pituitary gland. All of the following hormones regulate the F phase except number 1 glucagon, number 2 cortisols, number 3 aldosterone, number 3 catecholamines. Number 3, which one of the following will not exacerbate the metabolic response of surgical injury? Hypothermia, hypertension. Number C, starvation, immobilization. Number 4, which one of the following statements are false regarding optimal peri-operative care? Number A, volume loss should be promptly treated by large intravenous infusions of the fluid. Hypothermia and pain are to be avoided. Number C, starvation need to be combated. Number D, avoid immobility. Number 5, which one of the following interleukin promote the hepatic acute phase response in injury? Number 1, interleukin 4. Number B, interleukin 5. Number C, interleukin 6. Number D, interleukin 8. Hope you all solve these BCQ after the lectures. Thank you very much.